All right. Hello, I'm MIDN Matya. I'm the Arrest OPO, and I will be conducting this week's Extremis and Cardiac Arrest training. So we're going to start with cardiac arrest. So first things first, obviously, is going to be our criteria, right? So we're going to be looking for patients who are unresponsive without signs of life, patients that do not meet the obvious death criteria, which we will discuss later in this training, and patients that do not have exclusions from DNR, MOLST, or EMOLST orders. So a DNR is a do not resuscitate order, and a MOLST or EMOLST is a medical order for life-sustaining treatment. EMOLST is just an electronic version of that. Basically what that does is it gives you guidelines or limits of care that you can provide, while a do not resuscitate order means that you cannot resuscitate the person. So for our patients who are unresponsive without signs of life and meet the other criteria for cardiac arrest, obviously first things first, BSI scene safety, and then we're going to go right into check responsiveness, pulse, and breathing. So check responsiveness would be shout, tap, shout, and then pulse, obviously you're going to be check the carotid artery, and then for breathing you're going to look, listen, and feel for breathing. And now note that agonal gasps are not effective breaths. Basically, they're just reflexive gasp that doesn't actually result in any real oxygenation of the blood or tissue. So patient has no pulse, no breathing. So we're going to initiate CPR. So CPR, obviously for compressions, perform compressions at the rate of 100 to 120 compressions per minute to a depth of 2 inches for adult patients. And then for the breathing, we have a couple of options. We can either do the 30 and 2, so 30 compressions, 2 breaths, or we can do continuous compressions with asynchronous breaths. So that means you're breathing while they're doing compressions. This helps because it makes sure that the air gets forced in and forced out via the flexing of the lungs and the diaphragm that is caused by the compressions, and results in somewhat more effective breaths. In addition, for the breaths, proper use of suctioning should occur. So obviously if they have any mucus in their mouth or in their airway, suction it out. Make sure the airway is open. So either head tilt, chin lift, or jaw thrust, and then also consider the use of an airway adjunct such as an OPA, just to make sure the airway is open. So if we're doing the 2 breaths, we're going to wait the 30 compressions and do the 2 breaths and provide them over about a second's duration. You're looking for chest rise. Asynchronous breaths, you're looking for about 8 to 10 breaths per minute. Again, with the 1 second duration, looking for chest rise. And then obviously compressions get difficult, so try to switch out the person doing compressions about every 2 minutes, just to prevent them from getting too tired. And then obviously the next major key component of CPR is the AED, at least for BLS. So obviously we want to get the AED on as quick as possible. If it's an arrest that was witnessed by a member of the squad, then AED can go on right away before compressions. However, if the arrest was not witnessed by a member of the squad, compressions come first, and then you put the AED on without interrupting compressions. Obviously, you let the AED analyze and do what it needs to do, and then defibrillate as appropriate. In addition, for all cardiac arrests, ALS should be notified and requested. For a normal cardiac arrest, wait for ALS to arrive before initiating transport. That way they can get set up and get everything they need to get done before you leave. However, it's a traumatic arrest, so a cardiac arrest caused by trauma, then you're going to load and go, request ALS, and do an ALS intercept en route. In addition, it's extremely important to make a medcom note for cardiac arrests or any of the other cases covered in this training. So as I said before, check response and no signs of life, carotid artery, look, listen, feel for chest rise, agonal guests are not breathing, not effective breathing, no obvious death, no DNR or MOLST, compressions, AED, ALS, transport. So in some details, when you're doing your look, listen, and feel and checking for pulse, no more than 10 to 15 seconds. And then here at Kings Point, we use the team approach for CPR. So first person on scene, first member of the squad on scene is going to begin compressions. The next member is going to bring up the BVM, AED, and suction, and they're going to take over breathing and suctioning, and also set up the AED. Third person to arrive can assist in airway management or applying the AED, and then switch out with the compressor as necessary. OIC or crew chief, whoever the senior member is, should be in charge of the scene. Basically, their job is to make the call for ALS, manage the scene, make sure nobody interferes, and if they need additional resources or manpower, to request them. Obviously, for traumatic arrest, load and go, and then do an ALS intercept and route. General processing will be CPR, ALS, and transport. As you can see here, we're kind of going to have this similar setup for CPR. So one person's going to be doing compressions, one person's going to be doing airway, one person's going to be doing defibrillation, so watching AED, and also rotating out with the compressor as necessary. Pretty much everybody's just going to rotate out with that to make sure no one gets too tired. And then the team leader is going to be managing the scene, making the calls, things like that. The medication position in this instance would be an ALS provider, such as a paramedic. And then once they arrive, they're going to be working on their things, pushing their medications, getting their monitor hooked up, taking over defibrillation, so that the EMT who was previously working with the defibrillator and switching out will only be switching out with the compressor and person on the bag valve mask, ensure that nobody gets too tired while doing compressions. In addition, prior to transport, if ALS has arrived, in this case it'd be Vigilant, they carry the Lucas device, which is an automatic compression machine. Prior to transport, helps if you go ahead and put the Lucas on the patient. That way, compressions can still be delivered during transportation. Obviously, as per school policy, we're not going to do compressions during transportation because of the dangers. So ideally, use the Lucas. So to request ALS on the Vigilant radio, which the driver should bring to the scene, it would be 830, which is the radio code for Vigilant. 830, this is MM1. MM1 is us. Code 99, that's cardiac arrest. Requesting ALS. The reason you're going to specify code 99 is obviously it's a cardiac arrest. That's what the radio code for a cardiac arrest is. And it also tells the dispatcher why you need ALS. The dispatcher will then notify you when the paramedic, which is 8365 for the paid paramedic, is en route. And they may ask additional questions to provide information to the paramedic or to clarify why ALS is needed. If it's not a cardiac arrest, then you could call 830, this is MM1, wait for the response, then requesting ALS for whatever reason you're requesting ALS for, respiratory arrest, choking, anaphylaxis, etc. In that case, you would then continue to answer any questions the dispatcher has. And then for the MedCom note, which you will make in the ambulance on the MedCom radio while transported to the hospital, basically what it does, it just gives, we're supposed to give the hospital advance warning of what is coming in, what resources they need to have ready in order to effectively help the patient. So for MedCom note, you're going to begin with MedCom, Merchant Marine 1, which identifies us. You're going to wait for a response from MedCom. That way that you know that they've received it and they are standing by to copy that information. So you need to say MedCom, Merchant Marine 1 with notification for whatever hospital you're going to. Typically for us will be North Shore Manhasset, with a whatever age, male or female, with the chief complaint of whatever's going on. Then you're going to state patient's level of consciousness, vitals, and status, and whatever resources you were requesting from the hospital, as well as the ETA to the hospital. So for a cardiac arrest, it would go MedCom, Merchant Marine 1. Go ahead, Merchant Marine 1. MedCom, Merchant Marine 1 with notification for North Shore Manhasset with a 21-year-old male with a cardiac arrest. Patient is unconscious. Vitals are X, Y, and Z. Patient status is critical. Requesting a cardiac team on arrival. ED to the hospital, 5 minutes. And then you're going to wait for a response from MedCom to make sure that they got the information. They may also ask about the mechanism of injury, nature of illness, allergies, medications, past medical history, what have you. Provide information as you have it. If you do not have it, let them know that you do not have that information. And then for pediatric cardiac arrest, protocols are mostly the same. So obviously the same criteria as earlier. Again, CPR should begin prior to defibrillation unless the arrest is witnessed by the responding provider. Obviously, compressions are going to be at the same speed, 100 to 120 beats per minute. Then with pediatric patients, you can either do the 30 and 2 compression, single rescuer, or if you have 2 rescuers, you can do the 15 compressions and then 2 breaths. 5 cycles for the 30 compression, 2 breath is the goal. 10 cycles of the 15 and 2 in 2 minutes is the goal for multiple rescue CPR. Obviously, rotate compressors as resources allow to reduce fatigue. Use airway adjuncts and bag valve mask as necessary. You use BLS airway management, including suction. So basically, MPAs, OPA suction to manage the airway. Bag valve mask should always be connected to supplemental oxygen. Obviously, apply the AED as quickly as possible and focus on providing good CPR while the AED does its thing. For patients that are under 25 kilograms, so about 50 pounds, or under 8 years old, pediatric AED pads are preferred. If you don't have them, you don't have them. Again, do not delay compressions to begin ventilations. Do not delay ventilations for supplemental oxygen. And then transport quickly, following the same procedures as we noted before. So crest ALS and transport once they're on scene unless it's a traumatic arrest, in which case you load and go and then do an ALS intercept and are out. Once again, criteria: check unresponsive, no signs of life. CPR, 100 to 120, 5 cycles and reassess, and load and go unless ALS is on scene. 1/2 inch compression depth instead of 2, obviously because pediatric patients are smaller. Make sure the AED gets attached quickly. Make sure you're doing proper breaths with the BVM, using airway adjuncts and suction as necessary. Transport, rapid transport, and then MedCom note always. And then for turnover of a cardiac arrest patient at the hospital, you're going to kind of follow this format. So basically, age of the patient. If you have a paramedic or ALS provider there that can provide the initial and most recent heart rhythms, they will provide that. Whether or not the arrest was witnessed by the responding providers, whether or not bystander CPR was started, time since CPR was started, number of shocks given, also number of epinephrines given, which would be the paramedic again as well. Other medications and pertinent medical history. So if the paramedic gives additional medications, they would state that. You would state any additional history that you have that would pertain to this. What airway adjuncts are in use. And then end-tidal CO2, which again will be coming from the paramedic. So after cardiac arrest, we're going to go into foreign body obstructed airway, or choking as it's more commonly known. So basically criteria is going to be patients with a complete or partial foreign body airway obstruction. So that means they're having trouble breathing, they're choking. This has 3 different levels. So you have patient is conscious and can breathe, patient is conscious and cannot breathe, and then patient is unconscious and cannot breathe. So patient is conscious and can breathe. You're going to encourage the patient to cough, transport in a sitting position or position of comfort, and administer supplemental oxygen. With a pediatric choking patient, they may not tolerate a NRB, so you may have to hold a mask 6 to 8 inches from their face and can let them get their oxygen that way. Obviously, just use as tolerated. And And then you're going to continue providing supportive care on the way to the hospital and keep assessing the patient, watching from transition to either from conscious to unconscious, etc., or from breathing to not breathing. If the patient is conscious and cannot breathe, you're going to perform airway maneuvers. Basically what this means is you're going to be doing abdominal thrusts or the Heimlich maneuver on pediatric patients, or well, specifically infants, so less than a year old. You're going to be performing 5 chest thrusts and 5 back blows, not abdominal thrusts or Heimlich maneuvers. And then again, rapid transport, and then provide supportive care and continuous assessment. For unconscious patients, you're going to remove any visible airway obstructions by hand and then begin CPR following the cardiac arrest protocols for pediatrics. For adults, you're just going to perform CPR and go from there. So pretty much, conscious and can breathe, encourage coughing and provide oxygen, supplemental care, rapid transport. Conscious and cannot breathe, Heimlich maneuver / abdominal thrusts, oxygen, rapid transport, supportive care. If unconscious, remove visible airway obstruction, begin CPR, and then transport rapidly, make a medcom note if unconscious, and consider calling ALS. And then here we have a diagram for how to perform the Heimlich maneuver, or what to do once the patient becomes unconscious. So make a fist, place it above the person's belly button but below the rib cage, pull sharply inward and upward, and then continue until the object comes out or the patient can breathe. The patient becomes unconscious. Open the airway, open the mouth. If there's a visible obstruction, remove it. If not, head tilt, chin lift, give 2 breaths, and then perform CPR. And then next, we're going to respiratory arrest failure. So the criteria for respiratory arrest and failure is patients with absent or ineffective breathing. And these signs can include cyanosis, visible retraction, severe use of accessory muscles, AMS, respiratory rate of less than 10 breaths per minute, signs of poor perfusion. So cyanosis obviously is a blue tinge around mouth, hands, nose. Visible retractions or severe use of accessory muscles is going to be, you're going to see the muscles on the inside of the rib cage being used to breathe, the neck muscle going to be standing out trying to breathe. Altered mental status, again, you're going to check your ANO ×4, not there, then AMS. Respiratory rate of less than 10 breaths per minute is obviously less than 10 breaths per minute. Signs of poor perfusion would be, again, cyanosis, very slow capillary refill, things like that. So to provide care, you're going to open the airway using head tilt, chin lift, or modified jaw thrust, depending on whether or not you suspect a trauma. Remove any visible obstruction by hand. Clear the airway via suctioning, and then provide positive pressure ventilation using a BVM. If ventilations are not successful, then you would begin following the choking protocol for an unconscious person, so you begin CPR. And then if the breaths do go in, then you can then use BLS airway management with an OPA, and a bag valve mask is necessary, including supplemental oxygen. So the bag valve mask, obviously connected to supplemental oxygen. For an adult patient, ventilation should occur every 5 to 6 seconds and be given over 1 second and cause visible chest rise. For a pediatric patient, ventilation should be given every 3 to 5 seconds, and again, be given over the period of 1 second and should cause visible chest rise. You can then attach a pulse oximeter, and you should have a goal of an oxygen saturation of greater than 94%, greater than or equal to 94%. Again, do not delay ventilations to connect supplemental oxygen. Continue with your ongoing assessment of the effectiveness of the ventilations and the need for compression should the patient lose their pulse. And then make sure adequate ventilation is occurring. And then again, rapid transport and make a medcom note and possibly request ALS. because they can provide a more advanced airway that may help, or just additional assistance. So again, review for respiratory arrest and check your criteria. So cyanosis, retractions, accessory muscle use, AMS, less than 10 breaths per minute, signs of poor perfusion. Quest ALS, open the airway, head tilt, chin lift, suction, remove anything, any visible objects, use an airway adjunct if necessary to make sure the airway will stay open. And provide ventilations using a bag valve mask connected to supplemental oxygen. So 1 breath every 5 to 6 seconds for adults, 1 breath every 3 to 5 seconds for pediatric patients. Airway management with airway adjuncts is necessary, rapid transport, and MedCom note. And finally, we are going to cover the obvious death protocol. So obvious death is going to be used for any case where you arrive on scene and the patient either has a valid DNR, MOLST, or EMOLST, basically that indicate that no resuscitative efforts are desired by the patient, or the patient exhibiting signs of obvious death, such as body decomposition, rigor mortis, dependent lividity, injury not compatible with life, or a patient who has been submerged for greater than 1 hour in any water temperature. Body decomposition being parts of the body begin decomposing, rotting away. Rigor mortis is joints are locked up, a patient is basically frozen in position, cannot be flexed. Dependent lividity is going to be kind of blood flow to the surface, so red skin, some light marks where they may have been resting against things. And then injury not compatible with life would be decapitation, burn beyond recognition, massive open or penetrating trauma to the head or chest with obvious organ destruction, and then if the patient has been submerged for greater than 1 hour no matter the water temperature. And if those criteria are, if the patient meets any of those criteria, resuscitation efforts may be withheld, even if they've already been begun. If any patches, pads, whatever have been applied, they should be left in place. Notify law enforcement for a medical examiner. Patient may be covered, and if law enforcement allows it, can be moved. However, if there's any concern for crime, suspicious activity, etc., patient should not be disturbed. And then to review, obvious death. So the patient is unconscious and unresponsive with a MOLST, EMOLST, or DNR that says no resuscitative efforts, or they have obvious body decomposition, rigor mortis, dependent lividity, an injury not compatible with life, or the patient has been submerged for more than 1 hour. And then they call law enforcement. So that was the Extremis and Cardiac Arrest training for this week. Watch the video, answer the questions by, I believe, Friday. And thank you.